are those with the most experience. This is a voluntary public-private collaboration, thanks to the multiple professional organizations who are collaborating with these rounds. They are not intended to be redundant or replace any organization's initiatives. They are intended to be sharing of clinical experience, not recommendations or guidance. These ECHO clinical rounds you are now participating in are focused on healthcare providers sharing their successes and challenges with other healthcare providers. Thanks to Project ECHO, Dr. Bruce Strumminger and his team for the peer-to-peer learning platform we use for these rounds. Upcoming ECHO COVID-19 clinical rounds currently are all US noon Eastern time. Next Monday, September 7th, we are canceling EMS rounds due to Labor Day. We hope you take time off, but if you have shifts scheduled that day or are on service that day, we hope that you are already scheduled to be off for the next holiday. We'll pick back up with EMS rounds on Monday, September 14th. However, for next week, we will have Tuesdays, September 8th, critical care rounds. Next Thursday, September 10th, will be emergency department rounds. It is self-evident that our nation's medical response challenges are changing every day. We continue to work to identify topics for these peer-to-peer learning rounds that are most timely and helpful to clinicians. For the ECHO clinical rounds, we continue to have participants from all states and multiple countries. I think on Tuesdays, we had 3 other countries participate. Appreciate that. Predominantly physicians, nurses, and EMS clinicians participate on these rounds. Thanks to NETEC, the National Emerging Special Pathogen Training and Education Center, for their support with these rounds. These ECHO clinical rounds and NETEC's webinars are complementary to each other. Thanks especially for these emergency department rounds to the American College of Emergency Physicians, the Emergency Nurses Association, and the American Association of Emergency Nurse Practitioners in their support as well. We continue to receive questions for each of these rounds and apologize in advance we're not able to answer all of them. We do select some major themes from some of those questions and hope to cover some of those. With that, I'm going to turn this over to Dr. Bruce Strumminger.
Thank you, Rick, and welcome everyone to today's rounds, and particularly to Sagar Galwankar, who's going to be speaking to us from Sarasota today, and to our expert panelists. So I'm just going to go over a few housekeeping and logistic items as I do each week. Hopefully everyone can see my slides. So we love your questions and your comments. So please put those in the Q&A function on the Zoom toolbar at the bottom of the Zoom window. We'll be monitoring that and we'll try to get to as many of them as we can. If you've got technical or logistic issues, please mention those in the chat function, also at the bottom of the Zoom toolbar. Rick will be asking a crowdsourcing question, and the chat function is the place to respond for that. We are recording this session, and your attendance is consent to be recorded, so thank you for that. Today's presentation was linked to the most recent email, the PowerPoint that went out from Project ECHO this morning, and it will be on our website with a link to the recording of the session within a day or two. And we'll share a link to that website, which has recordings from the past 4 or 5 or more months. For those who would like CME and continuing professional development credits, we'll be offering those through the University of New Mexico, where Project ECHO is based. About 15 minutes before the end of today's session, we'll put a link in the chat to a survey, and we really, really value your feedback on these clinical rounds, and we read that feedback carefully. So please take 3 to 4 minutes to complete that. And at the end of the survey, which should only take a few minutes, you'll get an instant certificate, electronic certificate of CME for this session. And you'll have about 48 hours to complete that if you're not able to do it immediately. So these learning sessions are focused on improving patient care and health systems and supporting clinicians. We want to keep this as a political and commercial free zone, and we appreciate your cooperation in supporting that. Thank you. Just a word about data. When you register, when you answer the polling questions, when you share comments in the chat, that's all data. And we just want to ensure everyone that we keep it confidential and we take stewardship of that data seriously. With that, I'd like to share the microphone with Sharon Van Aersdale at Emory and NEATech to give us an update on the NEATech Education and Training Series. Sharon.
Thank you so much. Hello, everybody. Happy Thursday. My name is Sharon Van Aersdale. I'm the Program Director for Emory's Serious Communicable Diseases Unit. By background, I am an emergency department nurse. I'm also the Director of Education and Resources for the National Emerging Special Pathogens Training and Education Center, which we'll call NEATech. It's been an honor to be part of these clinical rounds. We are learning so much, we're hearing so much. It allows us the opportunity to do deeper dives, understand what information are you guys needing? What information are we seeing? What are we talking about? So we do have several webinars in the works. They're scheduled and should be posted to our website shortly. We have one on palliative care considerations. That's going to be on September 18th. We have one just updating COVID, kind of a state of the union. Where are we at with COVID? That is occurring on September 25th. We have one on PPE fatigue, which we have talked a lot about during all of the clinical rounds, whether it's EMS, it's critical care, or here with the ED group. That is going to be on October 2nd. And then we have several more coming later in October on home health. How do you care for family that's perhaps home? So please stay tuned and check us out at neatech.org. Thanks, Bruce.
Thank you, Sharon. And just want to remind everyone that the Association of American Medical Colleges is a partner in these clinical rounds. And usually Dr. Rosha McCoy is able to join us. She's not here today, but the AAMC has been supporting a fabulous clinical guidance repository on COVID-19. They update it weekly, and we just want to encourage everyone to visit that site to take advantage of the great resources that they've curated there. And now,
Bruce,
Rick, gotta hand it back to you for our crowdsourcing question of the day.
yeah, thank you. Thanks very much, Bruce. Last week we took a break from rounds, and it was purposeful in recognition of the multiple discussions we've had during rounds about mental health of clinicians, about fatigue, complacency. And it was our hope that people would take time off for their own mental health, in support of their own mental health, and also for a chance to reinvigorate. Actually, I was fascinated when we asked this question, I think on Monday or Tuesday, when actually one individual responded by saying he decided he was going to set up an online black and white print how to do operation. I was like, wow. Now, that's a good use of time. So please, if you hadn't responded to this question before and on previous rounds, please do now. What did you do during the time you would have spent participating in rounds last week? Before I introduce our speaker, Dr. Schneider from ASAP brought to my attention some of an additional important resource that is sort of unfolding as we speak. And I want to make sure Sandy has an opportunity to share that with the group. Please, Sandy.
Thank you. So I'm Sandy Schneider. I'm the Associate Executive Director at ASAP for Clinical Affairs. Last month, we did a series of amazing seminars, webinars, I guess they are, on the future of emergency medicine. And we originally decided to do that before we had COVID. So they tainted it a little bit and changed our focus. We're now doing a series of webinars on preparing for the next pandemic. There's one this afternoon on research. There's one tomorrow on information flow. How do we make sure data gets flowing through the systems? And there's a series that will continue till next week. I'm going to put these in the chat. I welcome anyone. They're free. Anyone to please join us in these incredible discussions.
Thanks, Sandy. Sagar, as I'm about to introduce you, I want to make sure I get Carol and Harry to please introduce themselves as panelists before we start with you. Carol?
Sorry, took me a while to unmute. Good morning, I'm Carol Cunningham. I'm an emergency physician and I am the State Medical Director for the Ohio Department of Public Safety, Division of EMS.
Thanks, Carol. Harry?
Hi, I'm Harry Seibold. I'm an emergency and EMS physician from Helena, Montana. I sit on air medical committees for ASAP and NAMSP, and I'm a consultant for the Forest Service, coming to you live from the Marin County fires this morning.
Yeah, it's hard to tell which fire you're at, Harry. Thanks for putting them out. So with that, it's an honor to introduce our speaker for today, Dr. Sagar Galwankar. He is Associate Professor and Director for Research in Emergency Medicine at Florida State University Emergency Medicine Residency Program at Sarasota Memorial Hospital in Sarasota, Florida. Sagar, I really appreciate you doing this today. Anxious to hear from you.
Good afternoon, everybody. It's a great honor to be here. Let's get on with the slides. It's visible. So we can get started now. Good afternoon, everybody. My presentation is about our work done at Sarasota Memorial Hospital in Sarasota, Florida. My name is Sagar Galwankar. My disclosure is that I'm an academic physician. I'm holding the rank of associate professor, and I'm also responsible for directing research and development in emergency medicine in our new program, which is in its second year. I also have an additional appointment as the staff emergency physician at Sarasota Memorial Hospital. I do not have any commercial affiliations. The objectives of my talk revolve around the 6 steps which I have used to present myself today. I'm going to briefly tell you a little about our health system. I'm going to talk about a little of COVID and our state and Sarasota, and what are the processes and practices we have adopted to really combat this surge of patients in this pandemic. We have really transformed ourselves during this pandemic and worked a lot on the science to translate it to the survival models which are existing across the world and learn from them. And then we could discuss some next steps we are going to take. A little quickly about our Sarasota Memorial Hospital health system. We started in 1925 with 332 beds. Today we have a 75+ bedded emergency department and 830 floor beds, including ICUs in every discipline. It's a level 2 trauma center and a stroke center with neurosciences fully developed. We have a 24/7 STEMI call and complete cardiac services. We have 2 residency programs, the emergency medicine and internal medicine. And we have a full-scale system of critical illness and injury. We put it all under CI2. We are developing a vibrant community-based emergency health system through our urgent care models and a huge ambulatory network in the whole county. We are starting our own oncology facility, and we are waiting for our approval for our EMS fellowship. So if you look at our approach to emergency care, it's a complete chain of survival from family medicine, outpatient medicine to emergency medicine, including transportation. We are one of the 5-star rated hospitals in the United States by CMS. And this is information which is very available out of the only 45 in the United States. And we have held this pride in a row multiple times. About SMH in Sarasota. Sarasota is a growing city. It's predominantly a geriatric population. And we, of course, have snowbirds or people who fly down in fall and live in Sarasota. They own properties there. The epidemic was announced formally in March 2020. A full-scale plan was implemented, keeping all protocols and processes in mind. We are very specific about the regulatory framework, about processes. That's why we get those ratings, and we didn't want to falter in that during this pandemic. So everything was pressed from the day go when they even anticipated the surge. 3 important parts which governed our whole approach is, are our patients safe? Are our workers safe? And are our residents safe? It was very, very important. And when we say workers, we all consider ourselves as humble patient care providers, either any staff member of the SMH health system. The key fundamental or the backbone of our response was a very strong infection control policy and a surge capacity modeling to take care of the patients, because all our patients, most of them are special needs. They come from nursing homes, they're geriatric, anticoagulation is on board. So we have those specific characteristics of our patient population, which we are very well aware of. Since March 2020, one thing which has struck me, which is quite a learning, is being the clarity in internal communication. The communication between the providers from the top management to the lowest is very clear, very, very precise and specific. They implement every infection control measure effectively, building on their 5-star system of rating, where they already implemented such system on a regular basis. So it was a part of their culture to just improvise, not compromise, because they are already out there. So they pressed in all the measures effectively. They engaged in innovation. So they thought about things out of the box. They engaged a lot in public education. So many of the patients were afraid to come to the hospital, they needed information. So they set up a very good public education portal. And most important, they brought teams together. So they created a new team, new task force. So things which were happening regularly, example, in the season, which we call it during winter, we are already surge capacity. So we are trained to that we don't want any of our patients to be left behind. So we just implemented that early on in March in a different way, because we needed to use infection control here more than just accommodating the patients. So we had to think outside the box, and many of the things we thought. Our focus was patient-centered care, patient-centered education, and patient-centered innovation. So all 3 forks of an academic department were put to play. The county numbers are very clear. We can look them up, but this is still a couple of days ago when I submitted my slides. 25 million patients in the world, 6+ million in the US. Florida has 623,000, Sarasota has 7,200. And along with this public system set up by all agencies, we had a Sarasota dashboard, which is live every day for people to see. So you can see our consensus. We still have about 200 beds vacant. We have 72 beds, but we had 46 patients. And we show how many are positive, how many went home, how many were negative. And most important part, we participated in the government system of community testing. So not only did we have clinical testing, we supported the Florida government in the community testing to guide people to go to the community testing center in Sarasota. So it was a holistic model where education, research, patient care, and participation in public health was done simultaneously along with education. It was a very, what I term as a proactive COVID policy. So they were ahead of the curve when it comes to following the guidelines. So they kept a watch on what was coming out every day and how does it apply to them. They instituted a strict visitation policy, which is crystal clear on the website and hung up everywhere as to who is not allowed. That means they not only isolated the patient, but they isolated the hospital from the community. That is crucial. And they put in strict infection control measures when it comes to hand washing, when it comes to hand sanitizing. The differences between washing and sanitization, very clear. The institution of asepsis, donning and doffing protocols. That means you leave the stuff inside the room, don't come out with it, keeping the doors closed. We didn't have curtains, we have doors. So we close the doors, we keep the patient isolated. Where do you eat? Where do you throw your stuff? Everything was gone to the smallest point. And strict goals of care model for admission. Who really gets admitted to the ICU? Who gets admitted to the floor? Who gets to send home under observation and follow up via telephone? All 3 categories, and every hospital did that. So GOC has been a hospital specific model because there were no uniformity in guidelines. Supporting Florida community testing locations was very crucial because our governor and our administration did a fine job instituting this, and we wanted the community to get tested at the same time. The other important part was the futuristic vision of participation in the COVID prevention trial and the plasma donation program. So we're very fast in instituting the donation model of gathering plasma from cured patients. The improvised patient care journey on the arrival of emergency medicine was we controlled flagging. That means immediately when we knew the patient is hypoxic, febrile, or any of the signs of COVID, they were flagged. Okay, this is a potential COVID. We need to institute the COVID model, isolating them. And this changed over time. So as the guidelines changed and as we changed those protocols, we created areas where we could put them. the treatment was goal directed. If they are in the septic shock phenomenon, if they meet the SIRS criteria, you do everything for sepsis. At the same time, you do the COVID testing when the testing became available. And at disposition, either we admit them or we discharge them was taken into account. One of the key features which they did was in the initial part of the epidemic, all the private hospitalist service were told that if the patient is COVID, it will be only admitted under the hospitalist service of the hospital. So they protected other hospitalists from getting exposed to these patients by keeping the hospitalist hospital service to be in charge of COVID care. So they could institute the guidelines. As we became, numbers started coming down, then everybody was engaged. But now any patient who gets admitted to the hospital gets a COVID test. And that's unique. So anybody who walks in and comes through the hospital gets a COVID test. Discharge the patient, then if it's a COVID test of 24 hours, we follow them up. So what did we do in the emergency department? We had infection control measures from day one. We avoided missing the blind spots. One of the major blind spot was lack of communication. We captured that. Other blind spot was lack of PPE. We captured that. Third was, which we saw everywhere or most of the places, was when workers talked to each other, they did not have protection. And they thought that we have to only protect ourselves from the patients. But many a times people forgot that they are a part of the communities. We will go out and they could get infected. This blind spot was caught very early. In fact, one of our papers is coming out, a comprehensive document on blind spots and near misses in COVID, which will be published very soon, which we are a part of that. So we overcame this blind spot by instituting universal masking. And that was key, that you cannot talk to each other if you're not wearing a mask. And everybody who walks into the hospital gets a temperature check. So we were very proactive in covering these blind spots. Employees' health support system, if anybody needs help, counseling, information, it was there. A strict rule of if you're sick, stay at home, don't show up. Even if it's the slightest thing, it's okay, don't come. I was febrile initially and I didn't go till they cleared me. PPE always in supply. We never fell short because they were used to the surge. They saw it coming, so they ordered it quickly and fast. And vitals before visit. We do not see the patient. Vitals are always first. That's very important. And the rule was followed to the T. We had a dedicated area for triage, but a unique thing we did was we put a telemedicine software there. So from triage, our physicians inside could see and decide what was going on in the triage and whether the patient has to be triaged or taken care. And we had blood being drawn in the triage. So we literally went outside and we were doing stuff, and telemedicine inside to outside was also a model which was uniquely used. Elective surgeries were stopped and now loaded with caution. And we had a dedicated critical illness and injury area, the CI2 area, which took care of these patients. The rules were anybody who can be COVID, everyone is at risk. We always took every task with a mask. And when we went into the patient curve, we had gown and glove. These were our core fundamentals. Every admission got a 24-hour COVID. Every suspected sure shot got a rapid test. Every procedure got COVID tested. Every ICU got rapid COVID. And every transfer we accepted also got a COVID. Education was all based on science. So we looked at the scientific education, ran public health programs and clinical programs also. Our residents went through a comprehensive training program by the World Academic Council of Emergency Medicine on ventilator sparing protocols. What we realized early on is that everybody was saying, prone the patient, don't put him on ventilator, but there were no guidelines. There were no check boxes to say, this is when you stop and you put the ventilator on. It was all hypothetical. And there was this back and forth where we couldn't come to a consensus. And that's when we approached the World Academic Council of Emergency Medicine, put a workforce together across the world from Italy, London, and India and UK, and make sure that we could come up with these guidelines to exactly see what we should do if a patient needs a ventilator or not. Because this was very important for ventilator sparing, because the right person should get the ventilator. Others, if they can be prone, we can save the ventilator. And we had daily education update in the hospital through an email. And if there was a drill needed for donning and dropping, we had the nurses and the doctors participating in that. We used simulation to a great degree in that. We used a simulation model to train our doctors. I'll go over some publications. We published a 45-page primer on COVID, the only comprehensive document at that time in literature with about 30 authors. We had consensus guidelines for every level, whether it's silent hypoxia and triage, whether it was the vent sparing algorithms, and whether it was the home oxygen therapeutic guidelines. We also wrote a paper which was highly publicized on COVID flu, where early on in the prestigious Journal of Shock, we anticipated that COVID and flu will be a bigger problem. Hence, early immunization with the flu vaccine is very important when we map the immunological pathways of COVID and flu, and we see that a flu vaccine could be counter-protective. And this paper was published in Shock. It's online. We've talked about telemedicine, our comprehensive document on science of telemedicine, on the 4 pillars of telemedicine on accountability, communication, patient record, and research is going to come out very soon, but this was our first paper. And we published our first data set of live data collection on patient care. Internationally, we participate in the World Academic Council Grand Rounds every Saturday at 9 a.m. for the last 25 weeks. We support data capture sites in the world. We also worked with the award-winning COVID control state of Kerala in India, which won the United Nations Award and today won the UK Award for the best COVID control in the world. So we were their consultants for training the whole state on our vent training protocols. We participated in the COVID merge study ran by University of Michigan, where it's in publication consideration. And we are also doing our own protocol on ultrasound guided COVID rule out in chest X-ray negative patients. We have worked with our colleagues in India to start plant-based intervention studies in India through the Indian government recognition in COVID. Interesting paper by our partners in India. We were talking about how many healthcare workers are infected. We supported our partners in India, which Dr. Hunt is very well aware, at All India Institute of Medical Sciences, to publish this first meta-analysis in American Journal of Emergency Medicine, where we saw that 10% of COVID-19 positive patients were healthcare workers. This paper is also available on the website. In summary, what we did at Sarasota was education, research, patient care, participation, policy, and public health all ran hand in hand. We tried to improvise and not compromise. We adhered to our best practices. We worked a lot in the policy development and policy implementation because both are equally important. And we did not differentiate between the patient and the processors, that is us, the healthcare workers. And there was no second to us. Plus, we didn't forget that the public from where our patient comes have to be informed 24/7. So this was our whole approach to the success. I'm very thankful to Dr. Hunt and everybody, Amanda and the whole team at DHHS. Thanks to their leadership, and I'm very grateful for being able to serve these patients and the opportunity. That's my Twitter handle and my email. Thank you very much.
Sagar, thanks very much. I really appreciate the presentation. There's a couple of unique things that I want to open it up to our panelists for any questions of Sagar or comments regarding his presentation. But okay, Sharon, I was going to ask mine first, but yeah.
I beat everybody to a hey.
Sharon, go.
And this aligns, I think, with some of the questions that we're seeing in the Q&A, but I wondered, you mentioned public education. What was the theme, or what was it that you targeted that you wanted the community to learn? I know that here in Georgia, we struggled a lot with masking and the importance of masking and kind of the those areas, but I didn't know if your healthcare system, if there was something specific that you all did.
Yeah, we spoke about many things about the COVID epidemic as such, what it is. We spoke about updates. We spoke about vaccination programs. So our videos are online. We talked a lot about back to school. That was a very big stress factor. And we created videos. So we have a fantastic audiovisual department and a PRO department who works. So if you go to our beautiful Sarasota Memorial Hospital website, you can see vibrantly all the systems. We have a dashboard. We have created a COVID policy center. We have created videos, and we are communicating with the people. If the people call us in the hospital, our hospital is very proactive in talking to them, because, you know, it's they had to improvise because they were at that level. And I give full credit to them because they literally made it happen. It was a 24/7 operation. And even today, they do the same. So, you know, it was connecting public health. See, the key feature was they didn't only focus on their patients. They concentrated a lot on the public health aspect also, that our patients need to be informed, they need not be troubled. They run a telemedicine. So they're very fast to institute telemedicine in their outpatient department because they have a very vibrant ambulatory system. But they also helped us institute telemedicine between the triage and the inter-hospital area. So it was like, you know, the model of the key features of isolation in a pandemic were all in the part of the process.
Carol.
My question actually kind of relates to insurance also. During the COVID pandemic, we've had reports of people fearing to come to the emergency department or to a hospital because they don't want to get COVID. Part of that, and I experienced the beginning of the pandemic as a patient, I think a lot of people were fearful to come to the hospital even if they did not have COVID symptoms due to the restrictive visitation policies. I mean, when you went to the hospital, it was literally like dropping a loved one into a black box, not knowing if they would, you know, if you could see them again. So I was wondering if any of your public health or your public communication and support included that, so you could address people's fears about being hospitalized for anything.
Yes, we had the visitation policy has changed over time. So of course it has been modified because we also cannot forget that patients who are non-COVID also fall sick. So, you know, we have a large geriatric population. People still have deliveries. We still have kids. We still have babies who get sick with other issues other than, you know, you have falls, you have trauma. So visitation policies were modified as the pandemic went on. But initially, yes, there was a lockdown phase and then it was eased, and who is allowed, what not is allowed. For example, now, if I have to talk to somebody, there is a specific corridor from which they are brought to a particular room where we go and see through a particular area. So it's mapped. You just cannot walk through any corridor. So it's like a mapped area from which you are escorted to a particular area and then you exit from the other area. And the talking and how we talk to them, how far we stand, everything is clarified to the most smallest point. And the best part is everybody is watching everybody. So, you know, there's always a charge nurse, there's always a doctor who says, don't do that. So they'll correct you, and they're there to, you know, checks and balances at every level. And that's unique. Like if there is a trauma alert, somebody is watching you, whether you followed the practice or not. And they will call on you later if you faulted or you didn't wear a mask or you didn't do certain things which you were told. Like if by mistake, sometimes you walk out of the room with you wearing that yellow gown, you will be stopped immediately. Go in, put the gown down there, wash your hand and go out. So that was very unique, and it's teamwork, right? When you abandon your ego and you understand that we all are in it together. That's what I learned. Like I've just been here for 1.5 years, but when we started the residency, but there's a lot of learning, phenomenally run operation, phenomenally run. And Dr. Hunt also is aware about the SMH model. It's very unique and different, and people just follow it because the patient population also cares for the hospital. There's a unique relationship they have with the hospital. People really depend on it. They respect the hospital a lot. So it was the responsibility of the hospital to connect with them. And this was a great opportunity to show that everybody cares and we are all in it together.
Thank you.
Sagar,
Team effort.
Yeah, Sagar, I got one question, and I really want to get to the polling questions because there's some particular importance around, they're always insightful, getting the responses, but these in particular today. So I want to get to that. But before I do, the blind spot piece and the attentiveness to the blind spot, there's a couple of things. I think back to what my NETEC colleagues taught me very early on about the absolute careful attention, watching each other. I mean, that one's like from the very first, you know, month of Ebola, few weeks of Ebola, that careful attention and checks and balances. And then as we've talked about now with mental health and Sandy's work with trying to like figure out the buddy system for emergency medicine, the buddy system that we have talked about on rounds in support of mental health, that are watching each other in a protective way. So here's the question, and it's a loaded question because I'm not sure there's any answer to it, but at least get your thoughts on it. So, all right, that check and balance, that careful attention to make sure we're not messing up and killing each other or killing ourselves with this. The fatigue and complacency, and the complacency word is over and over and over again on these rounds. It is like, yeah, and you know, I thoroughly expect over time, because of the complacency, the fatigue, the participation in these rounds, the participation in endeavors like Sandy's or ENA's or any others, and NETEC webinars is going to drop off just because we're tired of this. So how is it that, how do you sustain that really important check and balances of each other when we're in this really, really hard place right now with the fatigue and complacency? And I'm not looking for the 100% answer, but your thoughts on it would be very helpful, especially since your institution like really kind of like tried to nail it. You're doing publications, but it's a really important thing right now.
Yeah, the most important part was to understand that who really needs rest and who demands rest. So if the workers are getting tired, if they're getting washed out, everybody knows that there is a chance that when you stress out, you can make mistakes, right? So you have to know where to stop. And our emergency patient census literally dropped. So as you look at it, the number of patients who came, like Dr. Carroll pointed out very clearly, is the restricted number of patients who wanted to show. So the availability of healthcare providers to provide patient care was more. We could space out the nursing strategy, the critical illness area, the ICU area, the way they adjusted the nurses, they brought it down to the system. There was a lot of education modeling on protection, and the fatigue of the fact that when you wear the mask, you get tired. We had breaks, so we gave more breaks to people. We are very particular about feeding them, giving them water to drink, making sure enough breaks are there, because it's very important. And the policy that if you don't feel well, do not come. That was very important. The support of the hospital, that if you, at least for myself, I can tell you that they didn't allow me to come till I cleared. And that was very important. That was early on. I fell sick in March. So it was very important. And at that time, there was no information. The hospital system provided us all the masks. They did the fit test all over again. They made sure the nurses were safe. The people who were oncology nurses, like the patient, healthcare workers who are immunocompromised were isolated. They had a whole registry of those. The pregnant healthcare workers were isolated. So everything was worked on to the core. So three important parts were patient safety, worker safety, and public safety. All three factors were looked at. Nobody should harm each other. That was key. And the blind spot, like I'm telling you, the blind spot was the biggest one, where everybody assumes that we are healthcare workers, nothing will happen to us. And when you sit in the hospital, oh, we have to only protect ourselves from the patient. No, you have to protect yourself from each other too, because you don't know who is getting exposed to whom outside. Now that was caught very early. That's futuristic thinking. You didn't have to go to a webinar for that. You just thought about it. And that was a proactive step of, okay, we need to look at this blind spot. And in fact, that excited me to come up with the whole publication, where we got the blind spot think tank together to make sure that we have a comprehensive document on surge capacity blind spotting. And this is more like a supply chain model of Amazon. Actually, I got very enamored reading about blind spots when I read about the supply chain of all these big companies, of how they manage to get a product to us quickly. They think about every small thing where you can drop the ball. That's the power of supply chain. And that's how we started thinking about it, that what can we do? People can forget to get the gown outside. People can forget to put the mask. People put the mask only till here so that they can breathe. So you have to tell them to go up a little. Then, and when you put the respirator on, there can be a leak from the side. So how do you seal that leak? So all these small innuendos, small little tricks were told to them. Okay, you put a little strip here. Okay, you do this. Some people had obstructive sleep apnea, some healthcare workers. when they wear PPE, it really suffocates them. So, you know, things like that were looked at, and there were solutions designed. The areas were isolated where doctors sat and worked. We had different stations. We worked in different areas. We worked far away from each other because of electronic medical records. So a lot of things were put in, and we learn by the day. So if there is a mistake, okay, fine, let's modify it. Let's do it better the next time. In the residency training, we did simulation drill for the residents, because the residents were also afraid. They were just starting their residency. So getting them accustomed to the whole thing. So everything was done systematically, and it continues to be done. There is a daily report. There is a daily appraisal on what's happening.
Thanks very much, Sagar. I think there's some additional questions in chat. If you get a chance, take a look at some of those. But there's one topic that has come up in previous rounds, but this one as well, the whole issue of influenza and its impact on this. And I just want to point out that that's an ongoing one that we will need to address on the rounds, especially with your all populations, but Sagar, with your older adult population that you have there, that's going to be obviously a huge challenge. I want to go to the polls, and as I do that, let me introduce why these are a bit different than usual. As I mentioned, I think if I don't, I should, every rounds, that you see the poll results, and we share that here at HHS with the Healthcare Resilience Work Group at HHS. And as a result of many of the polling results, which are paid attention to in great detail, actually, the workforce shortage challenges and the workforce challenges in general continue to be topic here. We've done some polling on it. And actually the workforce team on the HHS work group really wanted to understand this better. And I think we all want to understand this better. So if you can hang on, I think these are more in-depth polling questions than the usual. And so kind of like take a deep breath, go get a drink of water or something, because we need to gut these out, okay? They're a little bit longer than usual. Just like we're gonna try to work through these. There's 8 of them, all except for the first one. There are multiple responses available for them. But we're trying to get to understand what it's sort of like, it's not the right phrase, but close to root cause analysis about why some of this is happening. So if you can bear with us, we're going to go through this. Amy and Amanda, if you can go ahead with the first one. Okay. Since July 1st, the biggest reason our healthcare facility has had staffing shortages is, and each one of these has healthcare facility, and the last option is I don't work at a healthcare facility. We have many EMS clinicians and leaders who participate on these rounds, as well as those that work inside healthcare facilities. And I want to make sure that those that don't work at a healthcare facility can vote too, because I want to see if we can get the highest percentage of votes that we can out of these. Interesting. You'll be interested too when you see the results. I know these are longer than usual, and just kind of like help me out with this. We got 51% of you voted. That's great. Just like another 10 seconds and we'll go ahead and see these. All right, go ahead. Let's take a look. 55% of you voted. Thank you. All right. The highest frequency, staff resigns, 16%. Staff ill, 10%. Staff quarantine, 10%. Leave it up there for a second so people can take a look. All right, thanks. Next. Now we start, the remainder of these are all, you can select all that apply, okay? So our healthcare facility has used the following strategies to increase staffing: longer shifts, more shifts, train staff to take on new roles with greater responsibility, new hires, utilization of field EMS clinicians, shared staff from other hospitals, request civilian federal healthcare providers, request, military, National Guard healthcare providers. And thank you those that are jumping on the I don't work at a healthcare facility and taking that one really fast. At least we know like who's voting, and it helps a lot. This is great. We'll do another 5 more seconds because 58% of you, 60% of you voted. That's great. Thank you. All right, let's stop there. 62% voted. I'm looking at them right along with you. Looks like new hires, train staff to take on new roles with greater responsibility, new hires by far. And then looks like the next most frequent is more shifts. I'll leave that up for like 10 seconds or so people can take a look. All right, let's do the next one, please. Again, select all that apply for this next one that pops up. What factors are contributing to hiring difficulties in your healthcare facility? I'm not going to read them. I'll let you work through them. And for just as a point of information, we did sort of an it was an adaptation of many of these questions for Monday's EMS rounds. So those of you who are participating who were EMS clinicians, your voices were heard on this topic of workforce on Monday. And those results were shared with NHTSA's Office of EMS as well. %56% of you have voted. Oh, I see one here, childcare for staff, that I missed as an option. Thank you for putting that in the chat. You're right, we missed that. Blind spot, Sagar, blind spot. I got them, lots of them.
Blind spots.
All right, 58% have voted. Let's see the results. Too few applicants to posted positions. Bruce, if I remember right, that and low recruitment pool, that was the same for EMS, if I remember right, in terms of being high frequency items. Low recruitment pool and too few applicants. Fascinating. And again, thank you for those that say you don't work at a healthcare facility. Appreciate your participating. All right. Give me just a second. I want to make sure people have a chance to take a look. Hey, Sharon, I'm curious, is that kind of trending with what you've seen from NETEC?
You know, it's not really something that we've looked at, but based off of these rounds, definitely seems to be something.
Yeah.
Trending.
Well, and that's part of this. It's trying to get down a little bit, well, a whole lot more deeper dive into this issue. All right, next. All right, how have financial hardships impacted staffing practices at your healthcare facility? So it's the impact, the finance impact on staffing. Promise you this doesn't go on forever. I think there's just a couple more. All right, about 5 more seconds. 51% of you voted. That's great. I'm always amazed. There are few that still haven't experienced financial hardships. Great, good for you. All right, let's see the results. And the most frequent responses to that one are staff have been furloughed, dismissed, 26%. Staff hours have been cut at 24%. Leave it for just a few more seconds. We'll do the next one. All right, next. I'm trying to like time these so people have a chance to see them. If people think I'm going too fast in terms of seeing the results, yell at me in the chat, please. Okay, so when your healthcare facility uses longer shifts or more shifts to compensate for staffing shortages, what are the consequences? Another 5 seconds or so. 54% of you voted. It's great. And also, for those of you who haven't participated before in the polling, we don't identify individuals in their responses. They're aggregated, not identified individually. All right, let's stop there. This one's pretty diverse in terms of the percentages. The burnout, certainly 38% looks to be the highest burnout. Yeah. We'll leave that up there for a second. All right, next. How is your healthcare facility mitigating issues observed with longer shifts? Should have had child support programs on here. There's a lot of options here, so we'll take a couple minutes on this one. There's 2 more polling questions after this, and then we'll go back to, in our usual fashion, go back to our panelists, and then to Sagar for last word here. All right, 54% have voted. Let's stop there. No mitigation practices looks to be like the leader in terms of frequency of response. And as I recall, somebody correct me if you think I'm wrong on this, but I think that was the same highest frequency response for the EMS question on this item. Yeah. All right, next. And echo, hey, Bruce, you and your colleagues are tracking with me so great on these polling things. I really appreciate it. This is like, yeah, I feel like I'm taking the boards or something here. All right, which of the following has your healthcare facility experienced during the COVID-19 crisis? There's a question in the chat while people are looking at this about, does HHS look at patterns or association or reciprocal answer patterns to these questions? In terms of like, you know, the HHS Healthcare Resilience Task Force, what, you know, I report out on like highlights from the polling when we have our leadership meetings. And then there have been some very specific instances where the polling results or something that happened that I reported on in the rounds caught people's attention, particularly actually a couple of, well, one was the workforce piece, another was on PPE that actually created not just discussion, but some action taken on that. So yeah. All right, give it another like 5 seconds. 54% of you voted. All right, let's stop there. Looks like the most frequent response is organizations losing staff due to inability to offer bonuses, raises, et cetera, and don't know. All right, last one, I think. Yeah, last one. For which professions is your healthcare facility experiencing staffing shortages? Select all and apply. And actually, of the questions, this one I'm personally most interested in seeing results on. Yeah, I see in the chat the answer about workforce and the percent of answers stating staff resigning is a challenge. Yes, indeed, eye-opening. I second that one. And yeah, I see the APRNs and APPs. Yeah, you're right. So the thing is, I don't have a committee working on these questions. Not looking to set one up either. Just saying. Uh, 51% of you voted, and the sort of like, it's a kind of a moving target with how the responses are kind of like unfolding. So I'm going to leave that up for another 5 seconds or so. And then after this final poll answer, back to our panelists for any final comments, questions, and then to Sagar. %53% of you voted. 5 more seconds, and then let's see the results. All right, 53% of you voted. Thank you. RNs, 45%. Fascinating. Custodial staff, 23%. You know, that particular custodial environmental services, wow, 23%. In a pandemic, that's a bad thing to happen. I'll leave that up for another 5 seconds or so people can take a look. All right, well, thank you very much. And appreciate your like responses, and you got to see them just like I did. And yeah, there's some insights there kind of special actually. All right, so to our panelists, how about Sharon, any questions, comments, then to Carol, then to Harry, then back to Sasha.
Yeah, so I feel like I'm always in line with what Harry's posting in the chat box. So we've been doing this we've been together too long now. But this reminds me of some of the conversations we were having a couple months ago now. This was back when we were getting about 600 plus participants. And a couple of the questions that we asked back then were, do you envision yourself being in this field in a year?
Right.
And I wonder what those responses would be now, seeing how high these numbers are, the concerns about burnout, the concern, staff leaving the profession. So it'll just be interesting to see how this all kind of plays out with staff working extra shifts, longer shifts. And then of course, childcare, that's huge, especially as schools, kids are now staying home and doing school virtually. So the impact of that on the workforce will also be interesting.
Yeah, the whole school thing, and the child care, huge blind spot on my part. The workforce team, actually, when we saw the responses when they saw the responses from when we were just kind of like having glancing questions on it, then they jumped on it. And then like they built that out. And I should have caught that one. So anyway, apologize. Carol?
I would echo the concerns with burnout. I'd be curious to see what dynamic things we can come up with to address burnout in the fall as we approach an even increased amount of disease due to influenza. And also to look at how many people are taking early retirements, not just resigning, but leaving the profession early because of that, if they have the opportunity. Lastly, you mentioned again your connection with the general public. We also need to try and prevent burnout of the general public. They're getting tired of wearing masks. How do we encourage them to go out and get their influenza immunization and stay out of the hospital? And again, they're dealing with childcare issues too. The holidays are coming. How do you be merry if you're in a mask and still staying at home in lockdown? So all these play out to our emergency department community, but also to the general public.
Carol, make a good point about, the whole buddy system concept. How could that, how do we work with the public on this piece? Because if there was ever a time for clinicians to use their voice, boy, this is it.
Yes, and we're coming off of a summer with no live music and baseball. People are, isolated. And social distance more than we've ever known. So bring back the music, please.
Bring back the music.
Yeah, give me some vitamin M. I'm dying without it.
Okay, so I got mine. Okay, all right. That's it's not like my final comment, but close. I got mine. All right, so Harry.
Yeah, great presentation today. I could not take notes fast enough here. There are some things that we don't talk about all the time. One of the things very early on that I latched onto in this was the point about communication. I think we have this need for clear communication that's ongoing and ongoing consistent messaging. I think if we get tired of doing that, assume people within your institution, within your agencies, and externally already know all this stuff and let it go, that we're going to be seeding the message to the rumor mill and social media and all of those things. So I think we need to continue with that consistent messaging and explore not only the traditional lines of communication that we're using, but expand those into some atypical means of communicating that message out there and communicating what we need to do internally so that we're able to all stay engaged and battle that problem with communication and discussion internally.
Thanks, Harry. Sagar, you get the last word.
First of all, thank you, everyone. This was a fantastic presentation, and I think this initiative is phenomenal, the ECHO initiative, to get people together.
Get closer to your computer, closer.
Can you hear me? I think it should be
better.
So, I'm very thankful and I'm very enamored by this initiative of bringing everybody together on the same page for the propagation of science, but also the discussion of systems and expressing solidarity. So, you know, working on our emotions, getting a way to talk about it openly. I think this is a fantastic platform, which is more like a relief rather than somebody badgering you to do something. So learning from each other is extremely important. This is a good key. This also puts us in a stage of something called as leapfrog. There is a lot of things we have to learn from the industry. We have been put in this situation in a leapfrog model where we have to embrace technology now in a bigger way, as well as prevention. Prevention was taken as a hobby. It was more taken like a vitamin pill. Now prevention is the key to survival. And it is the efficiency by which clinical medicine works with public health is what will be the success of the future. Whether it's school health, whether it's promotion of materials, prevention of the disease, or even practice of immunization at primary, secondary, or tertiary level. Supply chain modeling is something which we have always ignored in public health. Our core success of supply chain was the cold chain for vaccine, which was existing years ago, where public health showed that an efficient biosecured supply chain helps save lives. We have to focus on securing our supply chains, whether it's the human supply chain, whether it's the provision of care supply chain, whether it's the provision of food consumption supply chain, or medicines or tests. None of us are engaged in that level of supply chain dynamics. A failure of any pandemic rests on the failure of the supply chain. If we are able to keep the supply chain of education, research, and patient care at macro and at micro level, the engagement of every product line involved, we will be much ahead. So machine learning tools, when you learn from big corporations where you order a product and it gets delivered to you the next day, there is some strength in that. So we got to learn from that as doctors, and that prevention supply chain is very important. It's a huge subject, but when you think about it philosophically at a macro and a micro level, it's all about how does a secure oxygen get delivered to you? How does your food get delivered to you, which is clean and secure? All this is going to come to play because this is a new age, and how the vaccines are going to play out. So my only thing is united efforts without ego, but more complementing and collaborating is the way ahead. And this is just one of those tools by which we can get information out. And I'm very honored to be a part of it. I'm always available for any questions. My email is there, and I would love to attend these sessions in the future. And
oh, don't worry. The panelist invites. Yeah, ask Carol, Harry, and Sharon. They just keep coming. Eileen Fraser, I caught you there. If you have any words before we go, please unmute yourself. I'm happy to hear. If not, I'm good too. Pause for a second.
Yeah, good morning.
Hey, Eileen.
It was interesting because we run into, in fact, I was late on the call because I had to deal with a situation where a site surveyor wasn't allowed to come into a certain part of a hospital. And we were running into the same situations. I have just, out of 60 surveyors, I only have about 20 that are able to do any site visits. So we're suffering the same thing. And the malaise and getting tired of all this is going to be a problem even more as we go further on.
Yeah, and Eileen, Eileen's the executive director of the Commission on Accreditation of Medical Transport Systems, and I saw her pop up, and she, for those of you who haven't been on rounds before, people pop in, pop out. Sometimes you're on, sometimes you're not. And you know, if you're taking a break, great. If you're like doing a wildfire and like, okay, got it. No problem with that. We're going to end and this has been, I mean, in some ways long, but seems very short to me. This one is kind of odd in that respect. And Sagar, really appreciate your presentation. For the participants, yeah, and especially the 82 that are still hanging in there, it's like troopers, and like the polling thing, you've got it down. I mean, I'm not like waiting from like, okay, 14%, can we get to 18? I mean, you're like just jumping on it, you're there. And it really helps all of us. I mean, we're all seeing it. So it's great. And then to our, and by the way, on the polling, that's not so easy for the ECHO people, that kind of depth stuff. So thanks to you for sure. And then to our panelists always, and Sagar, again, you'll get the invites, no worries. But some of the pieces that you hit were really, I think, resonated with the participants for sure. My last word on this is, some of the wisdom I see in the chat, music and baseball, yes, Carol. If we have an apple pie shortage, life as we know it has ended. I hope people saw that, and I hope people baked pies this weekend, because we need to have life keep going. With that, thanks everyone, and we'll see you not Monday. Again, you take some time off, and if you're scheduled for shifts, you make sure that next holiday you're getting off. I mean, it's not right. You got to switch it off, okay? You know the drill, all right? And then next Tuesday, critical care, and then Thursday, emergency department. Thanks all, and have a great weekend.